have not done previously. So we're very excited to bring you 4 speakers, one of whom is longstanding faculty here at Columbia and 3 of our trainees. So this is a very lovely presentation amongst the 4 of them. So before I begin there, our usual preamble is that if you're participating via Zoom, please post your questions using the Q&A feature, not the chat. I still have to say that, surprisingly. As the online moderator, Dr. Talati will forward questions to me for our speakers to address at the conclusion of the full talk. So we will be taking questions only at the end, not after each individual speaker. We encourage trainees to consider asking a question, and we hold space for our trainees to ask questions first, both in person and online. Please fill out your CME surveys on the Zoom. It will be presented in the chat at about 12:15. For those who are in person, there are QR codes on the tables outside. It's now my great pleasure to introduce our speakers for today's session. Dr. Elizabeth Ford is an associate professor in the Columbia University Department of Psychiatry and co-founder and chair of the department's Justice-Involved Behavioral Health Work Group, and is currently still the clinical director here at the New York State Psychiatric Institute. Dr. Ford received her undergraduate degree from Yale University, her medical degree from the University of Virginia, and her psychiatric and forensic psychiatric training at NYU. She has provided decades of direct treatment and leadership in healthcare for people with mental illness involved in the criminal justice system in New York City, including as director of the Division of Forensic Psychiatry at Bellevue Hospital, as the training director for the New York University School of Medicine Forensic Psychiatry Fellowship, as the chief of psychiatry for New York City's Health and Hospitals Correctional Health Services at Rikers Island, and as the CMO for the Center for Alternate Sentencing and Employment Services. So this is like a great preamble for why Dr. Ford has been involved with our trainees. Dr. Ford's academic, research, and advocacy work centers on topics related to improving awareness about and quality of healthcare delivery to people directly affected by the criminal justice system. She has published extensively in scientific journals, in textbooks, and has authored a memoir. She and the Vice Chair of Education, Dr. Melissa Arbuckle, together developed a program to build collaboration between research and clinical training programs in our clinical services. To highlight what types of projects have been completed, she will be joined by Drs. George Denfield and Rohit Mukherjee, both of whom are T32 fellows, and Dr. Crystal Wang, a second-year resident in the General Psychiatry Training Program, who will speak on behalf of her PGY2 cohort. Dr. Ford will provide fuller introductions of each speaker as they take over the podium. The title of their talk today is Growing Together, a pilot program to advance clinical education research collaboration through quality improvement. Please join me in giving Dr. Ford and colleagues a warm welcome. Thank you.
Hi, thank you, Rebecca. Good morning, everyone. It is so nice to see everybody in person. I appreciate that. And also thank you very much for the introduction about what generally we're going to be talking about today. I will be doing the overview, and we'll try to go as quickly as possible because the stars of the show are waiting over here. I really want you to hear from the trainees. This is what I consider to be a good example of some of the goals of the restructuring that is happening right now. So it's a timely presentation because the program we're going to be describing is an attempt to really merge the 3 main missions of this institute, clinical, education, and research, and to do it in a way that's lasting and durable. We don't have any financial conflicts. Many people to thank. I'm guessing probably half this room, as well as many of the people who are online, all of the folks who are involved in clinical services throughout the NISP, and for one of the projects also in the CPEP at NYP. Particular shout out to Dr. Arbuckle, who you heard about earlier, but she was really instrumental in providing the time, the resources, the support, and the cheerleading for this endeavor. Learning objectives, you'll see in your handouts. So clinical, a little bit about what QI is, clinical quality improvement. It's officially a process to standardize procedures and structure to reduce variation and to reduce errors and improve outcomes for patients. QI did not start in the healthcare world. It started in the car industry world in response to significant errors in the manufacturing of vehicles. And actually an American scientist went over to Japan, the Toyota company, and helped investigate some of their practices to figure out why these errors were happening, and determined that in fact they were not all individual human errors. They were largely a function of the system. And what I hope you'll hear today, and what you'll think about in general, is the fact that most errors in healthcare the vast majority of errors in healthcare are not a function of a malicious individual or someone who doesn't know what they're doing. It's a function of systemic institutional practices and policies that have loopholes or errors or are not well fit to the work that's happening, are not created with the input of the people who are doing the work. And so you will sometimes get, particularly for bad outcomes, the Swiss cheese effect, where all of those loopholes line up. And the person who may have been the last one involved in some kind of significant event almost had no choice in their clinical decision making because of the impact of all of these influences on them. So QI is really, and I'm not going to read through all of these texts, but QI is really an effort to reduce errors through system improvement, and to do that with scientific methods. So to make sure that it's data driven, to make sure that it's feasible. We'll talk about some of these things a little bit later. And to also emphasize the just culture, which is that, again, errors are the result of systems primarily and not the result of individual folks. And I think over time, medicine as a field has tried to embrace this. There's probably still room to grow in that department. Who does clinical quality improvement? In my opinion, should be everybody. So everyone involved in clinical care. The hope is that they will also be interested in and excited about improving whatever the care is that they're providing. We're in a field that's constantly evolving, and we take care of patients who each have an individual history and profile. And so there isn't ever a one-size-fits-all kind of engagement with them. They should happen throughout all the clinical settings. There isn't a clinical space that cannot be improved. There's not a person who cannot be improved in their care and their working within the system. And the when piece is tricky. This is the phrase building or fixing the plane while it's flying. That's well known to me, but when I was talking with the trainees about this, they had never heard of that phrase. The concept is about trying to change and improve things while you also have to be doing those things. So an example of one of the projects that's ongoing now is about getting all the vital signs into the medical record. But you have to keep taking the vital signs, right? So we can't just stop taking the vital signs of patients so that we can take a couple weeks and figure out how best to get it into the electronic system. You have to continue to do the work while you're quote, fixing or trying to improve the work. And that, I think, is the trickiest part about QI. There are a lot of barriers, so many barriers, but also so many solutions. And the pilot that we're going to be talking about today is really geared with many of these solutions in mind. So NISP, as probably many of you are aware, does not have the most, and the state does not have the most user-friendly medical record system at the moment. That will change soon, but it does, without an electronic medical record system that is nimble and agile for report running and for data pulling, it's very hard to have access to the data that you need at the population level to be able to answer some of your QI questions. So that is a challenge that we've been working with. I'll talk in a second about how we've started to overcome that. There are always many administrative hurdles to many things. I think the hardest one in general in the systems that I've worked with, including in systems where they're actually opposing missions, is change resistance. So helping people feel excited about change, not feel degraded or punished by work they're doing when change does come around. And that piece has been, I think that's critical. That's probably staff engagement is the most critical piece to all of this. Couple of models of thinking that I've used over the course of my time to think about how to engage staff. The one on the left, is it your left? Yeah. Just highlights sort of the 4 generalized categories of staff who may be engaged in QI in healthcare settings. On the bottom left, you have people who may not have any interest in the thing that you're trying to change. They actually may not be involved in that kind of clinical care at all. They may think it's too much of a burden, particularly in really busy clinical services. Totally understandable. They may not think there's a problem. And also in that group are folks who really don't have the power to make change. And that is, in my mind, one of the most important groups to focus on with quality improvement. Again, because in my experience, if you keep things very rooted in the mission of quality patient care and treating patients respectfully and humanely, you will always find in healthcare settings a shared motivation for change. And so the work there is around identifying the motivation. And then people who don't have the power to change, both the low motivation and the high motivation group, that's the tide that's actually going to get things done. That's like the populace rising up and helping the people who are in the top part of that bar who do have the resources and may or may not have the motivation to actually get behind what's happening. It's so important to make sure that the leadership hears what's important to the folks who are actually doing the direct care. And then I think this graphic may be familiar to others, but another idea around staff engagement is that you've got a couple of people or maybe one person who has a really great idea. It's not going to go anywhere unless there's a cohort of folks who then get behind that. It doesn't have to be a huge number of people. Sometimes it's the people who may be influential with groups. And really, once you get over the hump of the early majority, the rest of it moves along and you have durable change. But again, like one great idea on its own does not make change in an institution. All right, so that's quality improvement in a tiny little nutshell. I do want to give a massive shout out to the quality management team. You'll see them in a couple of minutes on the slides. But quality improvement at NISP has evolved really considerably since 2023. There was the creation of a formal QI committee. Kim Leach, who's in the audience here, is the director of quality management at NISP. And the formation of that committee really helped spur many of the innovations that you're going to hear about today. Then in 2024, as the committee evolved, there were some very clear objectives. Also, back to QI, really important to have specific goals, to have very clear objectives. Treatment planning is the same way. If you don't know what you're going for, and if you don't know how to measure it, it's very hard to know if you've reached your goals or not. So you can see some of the clear objectives up here. And then in 2025, particularly with the addition of Sophia Pereira and Shonda Hines as the co-chairs of this committee, both of them are program evaluation specialists. The QI work has really taken off, and there's now an electronic process for project proposals and updates, really important. They have unearthed a huge amount of data that we now have access to, and that can be used to really help understand the challenges that we have and to then hopefully resolve them. 23 projects have started since the committee began, which is like a very large number, I would say. We probably don't need any more for the moment. 4 have been complete, 5 is on its way. This is the quality management team. Yay. This is really, really grateful for all of the support and guidance that they've given to this work. I think just in the short time that I've been in the clinical director role, it's really just been a real pleasure working with them and seeing the evolution of the care in response to these initiatives. Okay, so that's QI at NISP. Now, QI with respect to the education of residents and residents, fellows, I would argue even medical students, that becomes slightly more complicated, although the ACGME in 2017 made it a requirement that residencies across all specialties get some kind of education in QI, which then necessarily means that the fellows years later should have had that during their residency training. A study in Rhode Island at an academic medical center, however, found that by the PGY3 year, for a group of residents, they had received QI training and exposure, but it didn't really resonate with their confidence in their QI skills or their retained knowledge about what QI actually was or why it was important. And there is actually a very robust literature about QI and education. I generally summarizing it with this one note that active engagement in the QI process is generally thought to be a better learning experience for individuals than didactic sessions and talking about theory. And I can just attest in my own life that actually doing a thing and struggling through it helps me learn better than just reading or hearing somebody lecture me about it. Okay, so also challenges. to this, to having trainees be involved in QI experiences. Some of them are up here. Examples are that in general, trainees are not, well, not in general, they aren't permanent staff on the clinical services that QI is generally happening on. And so they are temporary and moving between these spaces, typically on rotations. That can make it very difficult to have continuity, to build the trust of the staff who really need to be engaged in this kind of work. There's also, depending on the training programs, limited dedicated time for this work. Again, shout out to Melissa because she provided that dedicated time for the pilot that we're talking about. And then also having projects that the residents will be excited about and that the trainees will be interested in. Any kind of work you do, whether it's clinical, research, education, whatever it is, if you don't really love it, kind of gets stale and old. And that's not what we want for QI. So in July of 2024, we started a program for the formerly T32, now postdoctoral physician fellows, to collaborate around QI. So they were given dedicated time to learn about and participate in QI projects across NISB's clinical services. And as a reminder, we have 3 inpatient units and 6 clinics. The goals of this collaboration were to make sure that the projects were directly focused on improving patient care. That's the primary requirement for these projects, and to be related as much as possible to the fellows' current works or interests. That it was highly important that the fellows collaborate with the clinical teams around their work. I will say that I was not I had room to grow myself in this first year of the pilot, and I'm trying very hard to work on that over the coming year. Education should be focused on learning about and overcoming the complexities of implementing change in healthcare settings. This is a research institute, so much, there's potential for tons and tons of research to be happening here. And there hasn't been, at least in my experience here, a lot that is directly related to what's happening in the patient interaction in real life. And that's what quality improvement really is. So wanting to also teach the fellows and the residents about not only how complex it is to implement change, but how possible it is to. And then to also, importantly, develop a working understanding of how to optimize care through QI. We started last year with 8 fellows across multiple specialties. I see some of the leads here, so thank you very much for coming. And then the NISB clinical leaders and specific project mentors were involved in that. We met every other week for group supervision. That was myself with the fellows, and then they worked on their projects when time allowed with their faculty mentors. And as the year progressed, there was more and more participation in NISB's monthly clinical QI committee meeting. Also important because that exposes the fellows to the structure of QI, and it introduces them to a whole range of people at NISB who they may not have otherwise met. In my experience in those committees, the addition of the fellows also added a rigorous kind of research and data element to some of the discussions that were had. So I do think the inclusion of the fellows really helped that committee as well. I'm going to show you 2 slides because I think they're important. I'm trying to pitch QI as well. This DMAIC is the most popular. This is part of a program called Lean Six Sigma. It's the most frequently used quality improvement process in the country. And it's designed to include these 5 specific regions. You'll notice that these map fairly well onto some research principles. If you've ever written an aims, like specific aims, some of these will ring true for you. The first is to define the problem and to make sure it's a problem. If it's just one person who had a bad day, that's not a problem for QI. If it is a repeated error that's happening because a policy forgot to include something in there, that's a problem. And to make sure to measure, very, very important. So a lot of our clinical decision-making can be based on anecdotes or the most amazing or horrible story that someone has heard. And that generally is not how regular healthcare happens. So to be clear that it is in fact a problem, to understand what the cause of the problem is or try to improve, and designing things that can potentially improve that problem is a big part of this work, and then maintaining it. It's not particularly helpful to have a really successful project that lasts for 6 months and then maybe the QI lead leaves and it just reverts back to what it was before. So really important to continue to monitor to make sure that the change happens. And then also very important to have SMART goals. Probably many in the room have heard about this already, but to have specific, measurable, achievable, relevant, and time-limited goals. Okay, I'm going to give you a quick example of defining a problem and then identifying a SMART goal. So one of the fellows, who is actually now our neurology consultant as of July, was involved in a project about improving access to consultations in the clinics for neurologists, in defining whether this was a problem or not, and in doing some initial data polls. Thank you to the QI department. We learned that almost a third of the Washington Heights outpatient clinic population was 65 years or older. We know that the older people get, the more the risk of cognitive impairment and dementia happens, and that we also know through some of the work of people in this room that the prevalence of diagnosed dementia is higher for people with SMI than for people without. And about 90% of our providers in the clinics had seen a patient in the past year for whom they were concerned about cognitive impairment or dementia. We also learned that it was near impossible to get a neurology consult in a timely way for those individuals. So if you look on the graph there, the wait time for a neurology consult was anywhere from never to a couple of months. So that's not good. That's not good. So the goal, and this is the SMART goal, was that by January of 2026, that was a year after this survey came out, 80% of outpatient neurology consults would be completed within a month. Hopefully you can appreciate how that's specific, measurable, achievable, relevant, and time limited. Our intervention was to create a new line and to actually hire a dedicated neurology consultant because the volume was so much, it really warranted that. And we were lucky enough to hire Dan, who is the fellow doing this project. And so now he's a dedicated neurology consultant for the service. And as you can see, as of September 30th, I mean, we've far surpassed the goal. And this is actually one of the projects that I may suggest we close. We may need to monitor for a few more months, but it's a really profound improvement in access to care for that population. These are the 2024 to 25 projects. So these are the fellows that started in July of last year. Won't go through them. You can read those. I will note, though, Sean Lynch up at the top, he is a fellow who started this year. He's joined Nina's project from last year, so that's why he's listed up here. The ones in purple you'll hear about in a second. These is the next year's class of fellows and their projects, what they're starting on. And then in July of this year, we added another group to the QI family, and that's the second year psychiatry residency class. So they have a 2-month block during which for each of them, for 1 month, they have a day devoted to doing QI work. You'll hear about that. That has been a slightly different model because it's a whole class and they only have a certain amount of time. There's one project and they're each taking 1 month of that project. You'll hear about some of the pros and cons of that, but from a supervisory perspective, it's actually, it's been quite nice to really force structure into the QI work and to have each resident have a very defined and specific task around the project. And the project was also picked specifically because we needed it on the clinical service and it seemed quite relevant to the work that the PGY2s are doing. Okay, so there you go. We'll have time for questions if you have any at the end. Now I'm very excited to introduce George Denfield, postdoctoral fellow in the Columbia Department of Psychiatry, working in the lab of Dr. Daniel Saltzman, where he studies the role of the frontal lobes and hippocampus in supporting our capacity for flexible behavior. George completed his undergraduate studies at Tufts University and received his MD and PhD from Baylor College of Medicine. He then completed his psychiatry residency training at Columbia, where he was the Leon Levy Fellow in Neuroscience and was awarded the NIMH Outstanding Resident Award. Outside of the lab, George is also a musician who plays guitar, piano, and sings, and has recorded 2 albums and played in several bands. Welcome, George.
Thank you. Right, so if you don't mind, I'll sing my presentation. So thank you for the opportunity to speak with you all today. I'm going to focus on the process primarily of developing my project rather than the details of the results, in part because this is an ongoing project, but also because I think they're valuable lessons to learn from a closer look at the development of a QI project. So as a neuroscientist, in addition to being a psychiatrist, I want to understand how the brain works and what goes wrong in psychiatric disorders. And as a part of that project, I'm actually very interested in the phenomenology of psychiatric disorders, including the subjective experience of psychosis. So on the right here is a series of self-portraits from an artist diagnosed with schizophrenia. And as a field, much work remains ahead of us in better describing the disorders we're trying to treat, not just neurobiologically, but clinically as well. So I think a big part of that understanding will come from learning from people's lived experiences. Others who share this impulse have developed semi-structured interviews that try to get at more detailed aspects of the experience of psychosis. And 2 examples of such interviews can be found here. And in thinking of a QI project, I was looking for opportunities to practice conducting such interviews, which were initially developed to explore the subjective experience of psychosis. And this led me to the OnTrack clinic. So OnTrack is a network of mental health clinics focused on the treatment of young adults with psychosis, and one such clinic is here at NISBE. And coming into discussions around this project, I was interested in what factors might impact engagement with OnTrack services. And I had the suspicion that one factor affecting engagement might be some level of active but subclinical symptomatology that these semi-structured interviews could help tease out. So as an example of what I mean, one domain of anomalous experience in psychosis that I thought could influence engagement pertains to the experience of other people, which makes up the 3rd domain of one of these semi-structured interviews. And the items in this domain refer to anomalous experiences of other human beings or the interpersonal world. The focus here is on experiences of social interaction, empathy or lack thereof, interpersonal ego boundaries, and the general look, feel, or influence of other persons. So to provide one example of what this looks like, the interview breaks these domains into further subdomains that can be explored. So for example, subdomain 3.1.1, loss of social common sense. So this is a sense of a lacking of a natural grasp or spontaneous understanding of other people's behavior or the social encounter. So one patient was quoted as saying, people move weirdly about, make gestures, movements without sense. And another patient was quoted saying, I simply cannot grasp what the others do. So these are more subtle aspects of psychosis-related experience that are not obviously captured by asking specifically about DSM criteria, but they could, if present, pretty clearly have an impact on social interactions, possibly in interviews for jobs or with clinical staff, and perhaps this is playing some role in employment and education attainment. So that was my theory going in, but the more important question to ask was, how does it interact with the clinic's actual needs? So the first step in developing an implementable project is meeting with some of the stakeholders involved. So Alana Nossel is the director of the Washington Heights Community Service, which includes OnTrack. And my first step was to meet with her to try to identify potential QI-related program needs. So she shared that the state identifies various benchmarks for participants to reach as part of their successful course in the program. And one of the few areas where NISBE was recently below the state benchmark was in relation to supported employment and education attainment. So that's displayed here. So the state expectation is that at least 65% of enrolled participants are competitively employed in a competitive internship or attend school as part of a degree granting program. And this graph shows quarterly results, mostly from the year 2023. On the top block is at NISBE, and the bottom is statewide performance. The goal is the orange dashed line, 65%. And we see that for the most part, both NISBE and the state are below the state benchmark. And I became curious to investigate participant engagement with supported employment and education services as a result. And some of you may be asking, what are supported employment and education services? So there's a model called Individual Placement and Support, or IPS, which was developed at Dartmouth and created a series of evidence-based supported employment programs designed to meet the vocational challenges that people with more long-standing psychiatric disorders have traditionally faced when pursuing competitive employment. On Track has two supported employment and education specialists, or Cs, Kat Luciano and Paula Lopez, who have been involved in this project very centrally and whose job it is to help participants define employment and education goals and then help them to achieve them. So my next step was to meet with the Cs themselves and get their sense of the barriers that participants faced. Because while I had the concepts of a plan, let's say, born out of my own curiosity, again, it needed to make sense on the ground at the clinic. So what emerged was the need to get a handle on what the level of engagement for participants was in the first place. So this was the first concrete step of the project, collecting data on participant engagement. So with Kat and Paula taking the lead, we took stock of where participants stood, and I'll just highlight one set of findings from that analysis here. So first, we found that nearly everyone in the clinic has met with the Cs at least once. However, only around 50% were meeting with the Cs on an ongoing basis, which was defined as at least twice a month. And then further, only around 10% of participants had a career profile completed. And this latter point really stood out as an opportunity. And to see why, it's helpful to know what a career profile is. So a career profile is a document that clarifies the participant's goals for work and/or education, asking questions such as, what are your long-term career goals? What's your work experience history? Are you interested in pursuing education or vocational training? And what is your school or vocational training experience history? So this is critical information for knowing how to assist someone in achieving those goals and boosting the clinic's performance up to the state benchmark level. But this wasn't always clearly documented, and an important question was why. So it turns out that a part of the profile is also to ask about substance use and legal history. And these are sensitive topics that may be uncomfortable to raise. And through further discussions, we learned that staff members were prioritizing building and maintaining rapport with participants first, understandably, but as a consequence of this prioritization, completion of career profiles was slowed in order to work up to these more sensitive topical areas. So that approach is reasonable, but it means that work and education goals were not discussed or documented as early on as they might otherwise have been, which presented a clear opportunity for a specific QI project. So in service of our overall goal of having 65% of participants employed in an internship or in a degree granting program, and in light of the data we collected, we formulated a specific objective to complete 50% of career profiles within a 6-month period. So the intervention we designed was to provide a specific and targeted training on asking sensitive questions in a personal history, as some staff members had never received such instruction before. And then as a related intervention, we instituted biweekly check-ins with the C staff, largely to keep track of how things were going. So this project is ongoing, and as my focus has been on walking you all through the anatomy of developing a QI project, I want to conclude just by reviewing a few quick lessons that we learned in the process. So 1, it's okay to go in with a specific interest, but be open to it changing. 2 was the importance of meeting with stakeholders. And 3, letting the data be your guide. So I went in with a specific goal, but through meeting with various stakeholders in the clinic to better understand actual needs and barriers, I was led to a much more concrete opportunity. And come January, we'll know how that's gone. Thank you.
Thanks so much, George. Now I'd like to introduce Rohit Mukherjee, who is an addiction psychiatry fellow here at Columbia. He graduated from UCLA's psychiatry residency in 2024. At UCLA, he was Chief of Justice, Equity, Diversity, and Inclusion, did research around racial disparities and overdose risk, and worked as a psychiatrist for a homeless outreach team. Prior to residency, he worked in harm reduction, doing outreach to drug-using communities and developing naloxone distribution strategies. His current work focuses on implementation of mental health services in syringe services programs and mitigating burnout among harm reduction workers. Welcome and good.
Hi, everyone. Thank you so much for having me, and thank you, George, for that great presentation. So I'm going to be talking about improving screening, diagnosis, and treatment interventions for patients with substance use disorders in the Washington Heights Community Service outpatient clinics. Now, this project basically started as New York State saw that there was differences between rates of individuals with a substance use disorder and thank you, I will now use the mic, between New York State and national samples of people with both SMI and a substance use disorder. So nationally, around 41% of people with SMI have a substance use disorder. When New York State pulled data from psyches, 6% of individuals had a diagnosed substance use disorder, leading to concern about underdiagnosis in general. And diagnosis and treating substance use disorders can be especially important in this population, given the impact of substance use on the course and prognosis of conditions like schizophrenia. Substance use increases the risk of hospitalization, homelessness, aggression, incarceration, and suicidality. And importantly, also impacts just treatment initiation, retention, and medical adherence too. And so New York State issued a two-pronged intervention and basically a mandate to OMH clinics. With the first phase being that there had to be implementation of universal screening using a valid tool within 7 days of intake. And then in a second phase, within 30 days of for anyone who's actually screened positive, to have a diagnostic assessment. Over last year, Alana Nossel and Jeremy Kidd worked on the implementation of the first phase. So basically identifying barriers, strengths for the different clinics, and then incorporating screening into the workflow in general, culminating in a screening training that took place July 2024. The starting with screening follows the paradigm of SBIRT, a science or endorsed strategy to improve diagnosis and treatment for substance use disorders. Basically, you start off with a validated screening tool, followed by a brief intervention for folks who screen positive, often involving motivational interviewing and then knowledge sharing, referrals for individuals who would benefit from a higher level of care, and then treatment using pharmacotherapy, and then also psychotherapy too. Now, 2 points about this. So SBIRT often has most of its impact when there's collaboration and buy-in. So more of like a whole community process too. And much of the studies for SBIRT too were done in primary care settings around alcohol too, with SMI actually being an exclusion criteria too, further emphasizing the need that to actually make success for all these adventures, these endeavors too, we'll need to actually leverage the experience that the Washington Heights community staff has with working with people with SMI. And that being said, I'm basically going to be talking about the screening, the S part of SBIRT. So New York State opted to select the alcohol smoking substance involved screening test, the ASSIST, as the screening tool to be implemented in the outpatient clinics. It's a gold standard screening test designed by the WHO in 1997 with validity and established in a 2006 trial. And then later was also established valid for SMI populations as well. It basically takes 3 to 15 minutes to complete, and then asks about 3-month and then lifetime use too. It results in a severity index, so mild, moderate, or severe. And in New York State, high risk would be anyone who screens moderate or severe. So that would be the people who would screen positive. And it's not equivalent to a DSM diagnosis, basically just a risk level too. My role in this was that Ilana and I wanted to actually see how the ASSIST was actually doing for the outpatient clinics. So seeing how many people were actually getting it. So I reviewed charts from July 1st, 2024, so right at the onset of after that training, and how to actually conduct the ASSIST to May 31st, 2025. So a total of 51 people were basically newly admitted to Audubon, Inwood, and OnTrack at that time period. And I wanted to see how many of them got this completed, and then also collect some baseline measures too. I collected demographics, whether the ASSIST was done, the ASSIST risk level for opioids, alcohol, nicotine, cocaine, and cannabis, selecting substances which were both common and then their treatments for, and whether or not there were diagnoses for these respective substances in the EMR Mahars and in the last psychiatry note. And lastly, I just noted whether or not there were medications for opioid, alcohol, and nicotine use disorders too. So we found that there was really high levels of assist completion among the 3 clinics, 80%, which really speaks to like the amount of effort the clinics are actually putting in to working with people with substance use disorders too. And in this sample, we saw that there were high levels of nicotine in cannabis. So I have rates of substance use disorders in MAHARS, the EMR, and then rates of risky substance use per the assist, mainly to just actually like notate differences in them too, and then also see where there could be areas of like help to the clinic too, with nicotine and cannabis emerging as primary things that we can actually work on in the future. And here I've just added a column about like rates of substance use disorders among people with SMI based off of the literature too, noting that nicotine and cannabis remain fairly high as an issue in this population, and that there are other differences as well, which we can notice differences in rates of opioid use disorder among people in the literature versus the new admissions that I had too. Overall, I found that a third of people in this time period would screen positive, were high risk for this cyst. 11.7 had a substance use diagnosis in MAHARS, and 23.5% had a diagnosis in a progress note. I'm coming back to this slide just to talk about how we can use this data to then inform both phase 1 and then try to actually like beef it up, for better words too, and then also inform the next step where we're hoping to implement the assessment piece within 30 days of anyone actually screening positive. And that leads to the fun part of actually having more discussions with clinic staff about identifying goals and how to actually like implement and make useful the assessment piece for people, where to actually like individual clinics fit in, where we can fit in the addiction consult service that actually exists there too, learning barriers and facilitators, and finding project champions who just be excited about all of this stuff too, which there's so many. And along the way, we get to actually find out educational and training needs, which creates an opportunity to learn together too. So that's basically where we're at. I wanted to thank a bunch of people, the staff, QIT members, the Addiction Consult Service team, and my T32 advisors. Thank you.
Thanks so much, Rohit. And then I'd like to introduce Crystal Wang, and also thank everybody for sticking around. We did get started a little bit late, so we're going to run over a little bit past noon. Crystal is currently a PGY2 psychiatry resident at Columbia. She studied economics and global health as an undergraduate at Princeton before pursuing a 2-year research fellowship in Kuala Lumpur, Malaysia, where she studied interventions for childhood nutrient deficiencies. She attended medical school at Weill Cornell, where she conducted research on trauma and volunteered in a free mental health clinic. Her clinical interests currently include addiction and sports psychiatry.
Hi, good morning. Thank you, Dr. Ford, for that introduction. Again, I'm Crystal. I'm one of the PGY2 residents who's been able to work on this collective QI project, which is focusing on reducing CPAP wait times for patients who are admitted to the inpatient units at NISP. And for anyone who's not familiar, CPAP stands for a Comprehensive Psychiatric Emergency Program. It's basically a separate section of the emergency department where psychiatric evals and psychiatric care is provided. And for anyone who came late and may have missed Dr. Ford's initial introduction, this is collaborative QI. This is a project that each of the 12 of us will be working on for 1 month during the Thursday afternoon of our outpatient rotation. And with Dr. Ford's supervision, we each complete a portion of the project and then we hand it off to the next resident at the end of the month. So I was the one who worked on this project in August, and I'm lucky to be representing my classmates and presenting this to you all. So talk about our progress thus far and what's to come. So a little bit on defining the problem. So how did we decide on what to target for our QI project? So this here basically is our main motivation behind this project. It stems from the systems map, which details the process from when a patient enters the emergency room at NYP, just here in blue, all the way through the time that they are admitted to the inpatient units at NISP here in orange. My colleague Kyle created this map. His picture's down below. He was the first resident to work on this project in July, and he collaborated with multidisciplinary staff in the NYP CPEP and also at NISP. And just going forward, I'll include the picture of the resident who worked on the contents of the slide at the bottom. And if there's no photo, then the work was done by me. So it's likely hard for you to read, and you don't need to read what's on the slide, but we show it here to highlight how complex of a system it is. It's two different hospital systems. Even though it may seem like simple for a patient to be transferred across the street from the emergency room into one of the units here, it definitely isn't a straightforward process. And as you can imagine, if it looks complicated to us, it likely feels that way for a patient who might be going through like a mental health crisis. And one thing I'll highlight here is that the time points in pink that you see throughout the map are those that we have trackable timestamps for, timestamps in the admission process. And so those are the points that we can target in our QI project as measurable outcomes. So having seen that map, it's not surprising that we were able to identify a problem with admissions, which is that given how complicated this system is, involving two different hospital systems, there's many variables and steps, there ends up being no standard expectation about when a patient would arrive on the unit and when they're being admitted. And for those of us here who aren't clinical staff, in general, admissions are very time intensive. They involve staff from multiple disciplines. So the lack of this expectation makes staffing difficult. It impacts the flow of the admission. Of course, it impacts the patient's experience of the admission. So stemming from this, when I came onto the project in August, I conducted interviews with staff at NISP to hear their thoughts about this. And this was building upon interviews that Kyle had done in July with attendings at NYP and NISP on this topic. So I spoke with staff members from various disciplines, including nursing, peer specialists, resident physicians, also MHTAs, or their mental health treatment aides, and they work on the units with the patients. And I asked each of them a standardized set of questions. So what's your experience with the admissions process? Do you think it matters what time of day someone comes in? Why or why not? How do you think the time of day of the admission affects the patient and their experience of the inpatient care? What have patients told you about the admissions process? And do you think it matters for a patient's hospitalization, how long they wait in the CPEP? And why or why not? Okay, so this is what I found, some summary themes. In terms of day versus evening admissions, staff had differing opinions. This is very likely dependent on their personal experience with admissions. Some of us only do nights, some of us only do days, many do both. And I've added some quotes here just to demonstrate what people said. So night admissions are disorienting for the patient because they never see the admitting physician again, and they have to repeat the whole process with the day team in a few hours. Someone else said, day admissions make it harder for an admitting resident to care for other patients, whereas at night you have more freedom, you have more time to conduct the interview. Staff mostly did agree that care in the CPEP is not the same as inpatient care. The CPEP is not as much of a therapeutic environment as the unit, especially for our first hospitalization. Someone said, I think being at the CPEP affects their morale. Patients feel that they can't progress. And overall, everyone agreed that expediting transfer from the CPEP to a NISP bed is in the patient's best interests. To be in need of treatment and sit waiting is a terrible feeling. So with these results in mind, I also conducted a lit review to see if what we had heard from the staff aligned with the literature on the topic. This is what I found. I'll just say a disclaimer that none of these studies were conducted in our institutions, and they also were conducted in a mix of medical EDs with psych consult, psychiatric EDs, and CPEP settings, which all provide psychiatric care, but a little bit different. And the main findings were that longer CPEP or ED wait times result in delayed mental health care. They're linked to greater patient morbidity and mortality via more adverse events such as agitation episodes, also associated with greater use of seclusions and restraints, associated with longer subsequent inpatient hospitalizations, and also worse functional and symptomatic outcomes at 12 months. And I'll point out that we can't really say anything on causality here. It could be that patients with more severe symptoms require longer in the CPAP before they're stable enough to be transferred to an inpatient unit. And then consequently, they require longer in that unit and also have have worse outcomes a year out. But notably, the literature did show that the timing of admissions, day versus night, seems to matter less for clinical outcomes, which is sort of what our staff was mixed on as well. So based on both the staff interviews and the SLIT review, we ultimately defined the problem and decided to focus this QI project on reducing CPAP wait times. So Sean down below, he was a resident who came after me, worked on this project in September, and I'll explain the process of what he did. So Sean looked at a year's worth of de-identified data on accepted admissions to NISP, and within this 1 year period, there were 161 admissions. And specifically, he measured the duration of time between the first NYP CPAP contact with NISP, which is when someone in the CPAP first calls a NISP attending to say this patient is, possibly suitable for admission, to the time that the patient departs the ER. And we're using that as a proxy for the patient's wait time for admission. And he found that the median wait time was 17 hours, which is a long time. If you remember that before they're determined to be eligible for admission, they've been in the ER for a long time, and then after they leave the ER, they have a ambulance ride between the hospitals. They have to go through security. They get transported onto the unit, all of which increases the time that they are waiting and the variability in their arrival time. So again, we say this is a proxy assessment because at that time when Sean did the analysis, we hadn't identified a timestamp that we could pull from the medical record that would tell us when the patient actually arrived on the unit, which is a great example of how in QI often the piece of data that you're looking for isn't readily available. But luckily, we have a QI team here at NISP who's helping us pull that timestamp electronically. Now, in terms of the data itself, you may notice that there's a bimodal distribution and also an end tail. So the data is separated out into short and long wait times representing less than 12 hours or greater than 12 hours. But we're not exactly sure why. It's interesting. So we'll be exploring this further. So with that said, that's been our progress thus far. And on this slide are some of the things that my colleague Drew Sura, who's working on this project now in the month of October, is going to be doing. So first, she's going to be updating the analysis using the actual time of arrival of the patient at NISP versus the departure time from the ER. And I'll just show this map again to demonstrate. I don't know if this mouse, you can't see the mouse, but basically the 17 hours represents the time between this, where the attending presents the NISP director, to the time the patient leaves the CPAP. And actually, we're going to be updating that to this time point here, where the patient arrives onto the unit. They meet with the MHTA, who completes a demographic assessment and enters them into the medical record. That's like the first point of care that they get on the unit. And we're hoping that this will more accurately represent the full wait time that a patient experiences. Beyond that, USTRA will also be further analyzing the data to assess for possible sources of delay. Could be bed availability, admission caps for the doctor on call, medical workup, or something else. And also, she'll work with clinical staff to identify a SMART goal. Again, that's specific, measurable, achievable, relevant, time limited. To start the process of formulating an intervention. And meanwhile, the data set will be added to over the course of months as new emissions come in. So we'll continue to be able to track that measure. So just some takeaways from the process so far. As mentioned, it's an interesting format for conducting QI where each of us only works on a project for 1 month. And it's very time limited. We each only have about 4 half days to work on our part of the project. And as we've mentioned, we collaborate with people from the CPAP, with staff all throughout NISP. So it's at times difficult to coordinate that within your limited time frame. But we do feel that having each resident work on a limited area of the project, and we have set goals in place for the month, and a structured timeline helps to facilitate progress. And we've been able to do a lot in the 3 months that I've presented to you here since July. Each resident brings their different perspectives and skill sets to the project, and also doing it in this format necessitates that we do high quality handoffs and communication between residents, which is always good for us to practice. I'll go next. Okay, so that's all I have for you today. I want to shout out my residents, Kyle, Yusra, Sean, all of whom couldn't be here today, for their work on this. We want to thank everyone in the CPAP and at NISP who we spoke to, who helped with this project. Thank you to the QI fellows who gave us feedback at each of the bi-weekly check-ins, and also Dr. Ford for your mentorship, for teaching us about QI. We've learned a lot, so thank you. Thank you.
Okay, lovely. So